You are listening to part 44 of our series, 7 Medicines, The Wise Woman Way, with Susan Weed at Time Monk Radio. Hello, Susan. Welcome back to Time Monk Radio.
Hi, Gemini. Did you go home and throw away all your acetaminophen and ibuprofen?
Well, no, I didn't. However,
I know.
I don't know why I keep them. I keep thinking, well, if I have an emergency and I don't have the herb I need or whatever, but after our conversation last week, I never want to take that kind of stuff again.
It's scary stuff, isn't it?
It's beyond scary. And to think that people give their babies ibuprofen and acetaminophen and they can piggyback them with fevers and unbelievable.
And many, many products that are sold contain these as well. As I, started looking into this, I mean, long lists of things you might think, you're buying a cold remedy and then you find out it has acetaminophen in it. And apparently this is how some of the deaths are occurring, that people are taking multiple drugs, each of which contains multiple drugs, and they wind up getting an overdose.
Frightening.
So let's continue on. Long-lasting opioids, extra caution needed. In 2010, the Center for Disease Control and Prevention reported that enough narcotic pain drugs were prescribed to medicate every adult American around the clock for a month.
Wow.
No wonder everyone checked pain.
Mm-hmm.
I had no idea that there was so much pain, that people were in so much pain, and that so many pain-killing drugs were, and this is just prescribed. Enough were prescribed to medicate every adult. That doesn't even include the ones that were sold over the counter. The overprescribing of opiate painkillers is a major contributing factor to an epidemic of addiction to pain-killing drugs, overdose injuries, and death for more than 2 decades in the United States. A recent article in the Journal of the American Medical Association Internal Medicine provides the first evidence showing that long-lasting opioid painkillers are associated with a higher risk of overdose than short-acting forms. Opiate painkillers, also called narcotic painkillers, directly affect the central nervous system, producing pain relief and drowsiness at the same time. They are prescribed most commonly to relieve pain, but are sometimes prescribed to relieve coughs. And they are used to cause drowsiness before operations. The short-acting forms of opiates are absorbed quickly and are rapidly cleared from the body, usually within 4 to 6 hours. The long-lasting opioids are absorbed slowly and cleared slowly, and typically take 12 to 24 hours before they are completely cleared from the body. Remember that older adults will require less than the usual dose. They have a greater sensitivity to all pain-killing drugs, and they do not metabolize them through their liver as well as they did when they were younger, nor do they excrete them as well through the urine. So not only can the longer-lasting opiates cause an overdose if too much is taken, they can cause an overdose even if the right amount is taken because the previous amount has not yet been cleared from the body. Patients having an opioid overdose exhibit 3 classic symptoms: pinpoint pupils, respiratory depression, that means their breathing is shallow and it's infrequent, and consciousness or semi-consciousness. Remember that opiates have a strong effect on the part of the brain that controls breathing. And so respiratory depression, respiratory distress is going to be a major thing that happens with overdose of opiates. And in some instances, breathing can cease completely. Risk also increases whenever an opiate painkiller is combined with alcohol. Sedatives, sleeping pills, or tranquilizers. All of these things work on the central nervous system, depressing the central nervous system, and here the sum of its parts is more effective and more active. Sleep medications, sedatives, antidepressants, ACE inhibitors, nicotine receptor blockers, over-the-counters, antihistamines, and cough suppressants can all include pain-killing drugs, and they can cause drowsiness, dizziness, blurred vision, slowed reflexes, impaired judgment, and hazardous side effects that can cause automobile crashes. Women have far more trouble with pain-killing drugs because their systems empty them of these drugs more slowly than men's do, and because hormonal fluctuations in women affect the metabolism of pain-killing drugs. As most women will tell you, and maybe it's true of you, that at different points in your cycle, you relate differently to pain.
Yes, I think that's true of most women I know, actually.
Yeah. Most of us, would if somebody said, "Oh, pain has a hormonal component," we would go, "Yes, my perception of pain is not the same every day of my cycle." So here are some tips for staying safe. 1, if you are going to take any kind of painkiller, start with half or a quarter of the standard dose. I, like you, keep some pain pills on hand because you think, you should have some on hand just in case, right? And I've had people say to me, "Oh, pay no attention to what it says there, to take 1 or 2. Take 3 or 4, that's better." You want to really hammer that pain, I've heard people say. You should take a bunch of them. The advice now is exactly the opposite of that. Take less. Take less and see if it works. If the standard dose is 2, take 1. Many of those painkiller pills are scored so that they can be cut in half. If you can cut it in half, cut it in half. I like to do this with the herbs. And to start with a low dose and to see how effective a low dose is, and only come up with a dose as we see that we need it for effectiveness. So even if you are already taking an opiate pain medication, you can still start to cut your dose down. Start low, go slowly up if you need to. If you're already taking an opiate pain medication, start shaving little bits off your pill. Get a razor blade and just shave a little bit and a little bit day by day. Make the pill smaller and smaller. Be sure that your doctor knows what other medications you are taking. One of the biggest risk factors for overdose and death from opiates is mixing them with other medications. The combinations of benzodiazepines, which are prescribed for anxiety or insomnia, and opioids is especially hazardous to your health. So talk to your doctor, talk to your druggist. Your druggist should know which drugs interact. If you're taking opiate painkillers, let your druggist know what other medications you're taking and make sure they don't interact. Make sure you follow up. Don't be afraid to tell your doctor that you want to come in monthly. Ask your doctor to order a urine test to measure opiate levels in your system. You need to be able to tell, and your doctor needs to be able to tell how well your body is actually clearing those opiates, because you can get an overdose from the opiates still in your system when you take the next dose. Remember that the era of the magic bullet is over. Nothing is going to be the magic bullet that gets rid of your pain and makes you feel absolutely normal again. Don't expect it. Remember, studies suggest that even opiate drugs can reduce chronic pain only by, at most, about 30%. The Rehabilitation Institute at Chicago Center for Pain Management says, we want to help people live their lives as fully as possible, and that doesn't mean that we can get rid of all of their pain. And remember that your opiate pain medications make you a target of thieves who like to sell them on the street. The people who are into safety are actually suggesting that if you're taking an opiate painkiller, you should keep it in a locked box and not tell anybody that you have it, so that you do not draw the attention of larcenous people. Painkiller Tramadol increases risk of low blood sugar. Accounting for about 44 million prescriptions in the U.S. in 2013, Tramadol, Ultram, has become a very widely used painkiller, especially in the treatment of chronic pain. This is most likely due to aggressive marketing, where it is said to be effective and safe, but the Public Citizens Health Research Group has designated it as a do-not-use drug. Even in the first few years after its approval, it did not appear to be as effective as other painkillers and was linked to serious adverse events, including seizures as well as addiction. A study published in the Journal of the American Medical Association has found that there is another unanticipated adverse side effect for Tramadol, and that is low blood sugar. Tramadol is a synthetic painkiller that belongs to a class of drugs known as opiate agonists. It is available in combination with acetaminophen as Ultracet. And despite the impression among many clinicians that Tramadol is safer than other opiate drugs, there have been increasing reports of deaths involving use of this drug. The number of deaths related to Tramadol tripled between 2009 and 2013. Package warning already has a worrisome list, including severe allergic reaction, seizure, addiction, interaction with other drugs, slowed breathing, and death. Withdrawal symptoms, including anxiety, nausea, tremors, and upper respiratory problems, occur if Tramadol is discontinued abruptly. It was classified as a controlled substance by the Drug Enforcement Agency, the DEA, because it has so many similarities to narcotic drugs such as morphine and codeine. Researchers followed patients for an average of 5 years. Of the 334,000 adults who prescribed either Tramadol or codeine for non-cancer pain, over 1,100 patients were hospitalized for low blood sugar. Tramadol use was associated with a 50% greater risk of hospitalization for hypoglycemia compared with similar patients who received codeine. The increased risk was most pronounced during the first 30 days of use, and more than 110 patients died in the hospital from low blood sugar caused by Tramadol. The true rate of what's going on here is probably a lot higher than what was reported in the study. Note that they only counted people who were hospitalized for low blood sugar. There certainly could have been easily double the number of people who actually suffered from low blood sugar, but not enough to result in a hospital admission. So, the bad news is painkillers are bad news. The bad news is a lot of us are in pain a lot of the time, and so we need and want things to help relieve our pain. How wonderful that there are lots and lots and lots of herbs to help us do that very thing. I sat down to write about herbs that help relieve pain. And the first question that came up for me was, what kind of pain? Now, I know that my list is certainly not exhaustive. As a matter of fact, it could probably made, 10 times longer and still not be exhaustive. But just kind of off the top of my head, I thought general pain, muscular pain, neck and shoulder pain, digestive pain, headache pain, flu and cold pain, pain from trauma, joint pain, emotional pain, gallbladder pain, urinary bladder pain, infected wound pain. We could certainly add, just between you and I, if we wanted to think about it, I'm sure we could add more, couldn't we? So pain is not necessarily a general thing. It is, in fact, when we're experiencing pain, it can be a very specific thing. There was a wonderful, wonderful article laying out a program for taking your life back from pain. I'd like to look at some of the high points of this program because I think it really steers us along the right direction. Point number 1, don't let the pain start. Well, now that sounds smarter than not, but what does it really mean, don't let the pain start? Those who exercise for at least 30 minutes 3 times a week are far less likely to suffer from chronic pain. People who are very depressed are more likely to suffer from chronic pain. So there's 2 ways to don't let it start. Get out and exercise and smile, whether you feel like it or not. I know it seems kind of hokey, but truly, smiling will improve your mood, and improving your mood will mean that you will have less pain. Don't let it start. I would also add to don't let it start, learn a little bit about how to move and use your body. Learn a little bit of Feldenkrais. Learn a little bit of yoga. Go to a Tai Chi class or 2. Learn some Qigong. Really get into your body so that you can feel the beginnings of pain. You've often heard me say that I keep a quart of tincture of Hypericum perforatum off, and I call it St. John's wort. Some people call it St. John's wort. Near where I sit down in the evening. If I feel any muscular pain when I sit down and go, time to relax, Susan. If I'm feeling any pain anywhere in my musculoskeletal system, I take some Hypericum tincture right then. That's my way of not letting it start. The second thing, give your pain a name. And I thought, are we really personalizing this? Are we talking about my pain, Jane? But no, they're not really talking about that. What they are asking you to do is to think back to what the kinds of pain that we were talking about at the very beginning. Do you have pain from inflammation? Do you have a dysfunctional pain? Or do you have a neuropathic pain? Inflammatory pain becomes chronic pain because we don't counter the inflammation. Wonderful anti-inflammatory herbs help counter the inflammation. And so in this situation, then, those anti-inflammatory herbs become our pain-killing herbs. In the same way that aspirin is a anti-inflammatory, and the name of the whole class of drugs is non-steroidal anti-inflammatory drugs. So the pain-killing drugs are primarily anti-inflammatory drugs. There's a wide range of anti-inflammatory herbs that we can get into and talk about to relieve inflammation. So that's one possibility. Two, you can have pain triggered by damage to the nervous system. Fibromyalgia and irritable bowel symptoms are linked to this kind of dysfunctional pain. When we have an injury, the body likes to keep reminding us about it in the hopes that we won't do it again. Unfortunately, that reminding us about it can take the form of chronic pain. One of my favorite techniques to counter this kind of dysfunctional pain is to imagine that you are made of space and that anything you impacted is made of space, and that space is going through space. I just got a letter the other day from a student. She said, I was walking downstairs, and I tripped near the bottom of the stairs and fell forward with my arms full and smashed the front of my face, including my nose, directly into the wall. She said, I heard something snap, and there was shooting lights, incredibly intense pain in my nose and my head. I thought I was going to throw up. I felt dizzy. It really took me a while. I had to sit down to get a hold of myself. She said, well, I wasn't at home, and I had to get home and take care of myself. I figured I'd get home and put some arnica on it. I would probably have, at the very least, a bruised nose and maybe even a broken nose, she said, but I just wasn't going to look. I was just going to drive home and deal with it. She said, as I was driving, I remembered you're talking about being spacious, and so I thought, I am space. And every time my brain would throw up an image of my smashing face first into that wall, I would say, the wall was butter and I am space. And I just, over and over again, she said, because my mind would throw it up to me over and over, I would over and over just feel myself sinking so easily and softly into the butter of the wall. And when I got home, and I went right to the bathroom to get the arnica, and I looked in the mirror, and I couldn't believe what I saw, because what I saw was a perfectly normal face. No bruising, no blood, and no pain. So that's also part of, don't let it start. Don't let your brain keep telling you smashed into something hard. Make it better. Don't let it start. And when the nerves themselves are damaged, neuropathic pain can be triggered. This can happen during surgery. This can happen in the spine. Certain viruses can do damage to the nerves and so on. So in terms of medical treatment, inflammatory pain, dysfunctional pain, and neuropathic pain are going to be treated differently So when we suggest that we name our pain, then what we're suggesting is that we look more deeply at what the cause might be. In fact, dare we say it, we're even being encouraged to engage in story medicine. What's the story? What's going on with your pain? It is important to remember that you're not crazy. People with chronic pain, well, you know, it's hard to get people to believe that you're really in chronic pain. It's hard to get doctors to believe you're in chronic pain. Oh, you know, when I first wrote Menopausal Years, The Wise Woman Way, there was this thing happening with menopausal women, and I called it Sore All Over. And they'd go to their doctors, and the doctors would say, you're not really in pain, you're just imagining it. Here, take a sedative. But they really were. Now we call it fibromyalgia. But it took many women and really decades of pushing the doctors to say we're not crazy. I'm including myself in, although I do not have fibromyalgia. Right? But this is not a craziness. This is an actual thing. A team of Stanford University researchers found a way to diagnose pain using MRIs. In fact, they can look at your brain and tell exactly how much you hurt. Neuroscientists are now using this technique to confirm when people are or aren't in pain. We can also see if the treatment has actually been effective at the level of the brain. So certainly the best possible thing would be to have health care in which you are believed and your pain is believed. But if not, well, then you can get an MRI and they can see. Treat it right away. How come? Well, because it hurts right away. Also because if you don't treat it right away and then you get chronic pain actually causes you to be depressed. And when you're depressed, well, then you hurt more. Chronic pain reduces the volume of brain tissue, and it can age you by up to 20 years. In fact, we find that the sooner that any kind of pain is dealt with, the less likely it is to become a chronic pain. So, next week, we get to come back and we get to talk about non-drug treatments. We get to talk about herbs and, of course, other things as well, because there's a variety of things besides herbs that we can use to help relieve pain. I hope I have made the case against pain-killing drugs. That doesn't mean that we all won't probably keep some around just in case, but I certainly hope that this encourages us to think once, twice, or maybe even 3 times before we reach for that bottle of pain-killing pills and say to myself, what can I use instead? Maybe you'll even get a tincture of some of the herbs that we talk about and keep it right next to that bottle of pills on the shelf so that you'll reach for the herb before you reach for the pills. Thank you so much for having me here at Time Monk Radio. I so enjoy all that we get to do together here to reweave the healing cloak of the ancients, to reestablish herbal medicine as people's medicine, the medicine that grows right outside our door, that's right there for the picking. So come and join me at any of the places that I'll be teaching this year. You can find my schedule at thewisewomanbookshop.com. Or maybe take a correspondence course with me. I really encourage people to take correspondence courses. It's, to me, one of the favorite ways of teaching people, and many people really like it. I don't make you turn in any lessons at all, and once you're a correspondence course student, you are a correspondence course student for as long as you want to be, because to me it's about relationship between us, and relationship between us and the plants. Green blessings, Gemini. Green blessings, everyone. Talk to you next week about ways to relieve pain without drugs.
Thank you, Susan. It's always our pleasure to have you at Time Monk Radio. And this concludes part 44 of our series, The 7 Medicines the Wise Woman Way with Susan Weed at Time Monk Radio.